Okay, we're moving on to contraception. I will break that up into several videos. This is just an intro. Sorry, we're going to proceed here. Let's move this. Thanks. Okay, facts about contraception. Fact, 45% of all pregnancies in the United States, the country with the best access to health care and spends the most money on health care, are completely unplanned. Fact, allowing for proper timing and spacing of pregnancy decreases risk both to the offspring and to the childbearing person. The ideal timing and spacing, as I said in the first video, is about 2 to 5 years. Fact, mistimed pregnancies cost money, decrease economic and educational opportunities for men and women, and increases poverty. And we all know that people do work after they have babies, or they can go to school, but it's much harder to put your full energy towards your career or your education when you are also raising a child. Fact, 42% of unplanned pregnancies end in elective termination, excluding pregnancies that are never even measured because they end in miscarriage before the person can terminate. That's a very high statistic. And it's unfortunate and it's unnecessary in many cases. Fact, women who have an unplanned pregnancy are at higher risk for postpartum depression. And I'm going to just slide through these. It takes a minute. Myths. Some methods of contraception cause abortion. No, they work actually by preventing the sperm from meeting the egg. Somewhere in the journey of both of those gametes, there's going to be a point where, let's say it's an IUD. This is the one that people think of as causing abortion. It actually causes the cervical mucus to become inhospitable, and it causes the lining of the uterus not to develop. Emergency contraception also does not cause abortion. It actually only works prior to ovulation. Once the ovum is released, it has no impact. So what it does is, you know that the sperm has that 5-day window where it's viable. It's going to try and prevent ovulation from happening before that ovum can be fertilized, released and fertilized. Myth, the pill causes infertility. Sorry, I clicked a little too fast. It does not. It can actually preserve fertility for some clients, especially clients who have hormonal imbalances like polycystic ovarian syndrome, by decreasing the effects of prolonged androgens. Myth, certain positions or hygienic practices prevent pregnancy. I'm not going to list them, but just no. No, no. Douching will not prevent a human from developing, and neither will any position during intercourse. Women can't get pregnant while they are breastfeeding. Totally untrue, and most women who've had their children close together can tell you that. We will discuss lactational amenorrhea method, but it has certain conditions, and if you're outside those conditions, you certainly can get pregnant. Myth, a woman cannot get pregnant during her first sexual encounter. No, that is not true. Myth, a woman can only get pregnant if she has an orgasm. I was floored to think that people actually thought this. But it is true, and some of them are actually in Congress right now. That is not true. Anytime a woman has intact ovaries and a uterus and there is sperm involved, a woman can get pregnant. Hormonal contraception does not cause cancer, but if you have an estrogen-sensitive breast cancer, then any method that uses estrogen is not right for you. Myth, women over 40 don't need contraception. Oh, no, no. The highest number of unplanned pregnancies is among that age group because they think it can't happen. Their fertility does decline sharply after 35, but it does not prevent pregnancy altogether. Myth, women who are raped can't get pregnant. Again, totally false. It does happen, and it's traumatic. Teaching adolescents about contraception promotes early sexual activity. No, they have sex when they have sex. Giving them the information they need to do it safely and avoid pregnancy actually impacts their life pretty profoundly. Promoting access to contraception promotes promiscuity. There's no evidence to say that that does happen. What you're really trying to do is to promote responsibility for your health. And that's your myths about contraception. And I'll show them again because this doesn't want to seem to move on. I'm going to click really fast through all of them. And now they have to go away again, sorry. This is the way I set up the fly in, fly out. All right, so how do we counsel people? Well, Turns out there is no one best method. The best method is the one that the patient or couple will actually use consistently and correctly. It is no good to tell somebody that the pill is the right thing for them if they're not going to take it. Take a thorough health history, as some methods are contraindicated with certain conditions. We'll talk more about that when we talk about each individual method. Ask them what their preferences are. Some people do not want to insert anything. Some people do not like condoms, or they're allergic to latex. Discuss perfect use versus typical use. Very important. It's important that people understand that just because something is 98% effective if you use it perfectly does not mean that their mileage won't vary depending on their own behavior. So they should have backup methods. For example, if you go on vacation and you forgot to pack your birth control, have condoms just in case, or run to the drugstore and get some. Or you can use emergency contraception if that's something you're willing to do. You need to counsel patients on the effectiveness of different contraceptive methods. People vary in their tolerance for risk here. Some people, they're in a stable monogamous relationship and they're like, yeah, I'd really like to put it off for a couple of years, but if it happens, it happens. Other people might be like, absolutely not. I cannot get pregnant. It's harmful to my health, or I can't afford it, whatever. So find out what their risk tolerance is. The most effective methods are permanent sterilization, contraceptive implants, intrauterine systems like the IUD. These all have less than 1% failure rate, and it's because it takes human error out of the equation. Once these methods are in place and they require a healthcare provider, the person doesn't have to think about it, in most cases for years. Moderately effective, we have all your hormonal methods like the birth control pill, patch, NuvaRing, Depo-Provera. These are about 93% effective on average. And again, a lot of it depends on behaviors. If you're on the pill and you need to take it every day and you forget sometimes, that's going to impair its ability to work for you. Sometimes a weight gain or BMI might interfere with the hormonal action. And if you don't go in and get your Depo shot, or don't go to the pharmacy and refill, you're susceptible to pregnancy. And then we have methods that are just inherently less effective than the others. Sometimes these can be combined to increase the effectiveness of either, and they might be more acceptable to some people. For example, barrier methods like the diaphragm, cervical cap, condom, spermicide, they don't have any risk to a breastfeeding mother. They're relatively inexpensive. In some cases, like condoms, you can get them for free. And if you combine two methods or more, you're a little less likely to get pregnant. So some people might prefer that. Fertility-based awareness, that can vary. Typical use is 24%. There's one method that could be theoretically 98%, but this again depends on the behavior of the person. Withdrawal, coitus interruptus, or pulling out, has a 22% failure rate. And random chance, which is just not using anything, has an 85% failure rate, meaning 85 people out of 100 will get pregnant if they use nothing. Okay, considerations. What you're going to do with this slide, there's a lot of stuff on it. And I don't usually like to have so many bullet points, but you could probably cut and paste this into a cheat sheet. And when we go through in class, I'll probably have that kind of cheat sheet for you. What's right for one patient is not right for everybody. Is it safe? So, estrogen-containing methods, increased risk for blood clots. Are there health concerns that are incompatible with pregnancy? So, for example, somebody who has severe cardiac disease should not get pregnant at all and might need that highly effective, less than 1% failure rate method. Are there health concerns that would make the method less effective? For example, is your BMI higher? That might make the patch, the estrogen birth control patch, less effective. If you are taking certain medications that aren't compatible with estrogen-containing birth control. Can you tolerate side effects? For example, if you insert a copper-containing IUD, you might get heavier menstruation. What are your plans for pregnancy? Short-term, long-term. You're not going to have somebody do a long-term method if they're thinking that maybe a year from now they want to get pregnant. How strongly does the patient feel about avoiding pregnancy? Again, like, well, if it happens, versus absolutely not, I just can't. It would be devastating. How many partners does the patient have? How frequently do they have sex? You're not being nosy. You need to know their risk for STIs and how effective that contraception needs to be considering the frequency of their sex life. Somebody who has a date night once a week could be okay using a less effective method. Somebody who's having sex with multiple partners or many days out of the week probably has a different need. Are you comfortable touching your genitalia? If you're not, don't even talk to me about the diaphragm. It's not going to be the right method for you if that's a turnoff for you. What religious or cultural beliefs does the patient have about contraception? Roman Catholics, for example, it's a doctrine in the church that most American Catholics don't follow, but artificial birth control is prohibited. And if that's important to you, and it's more important than avoiding pregnancy, then maybe we do want to talk about fertility-based awareness or fertility awareness-based methods. Does the patient have a condition that would be improved by the use of a method? For example, somebody comes in and they've got heavy, painful periods. They might do better with something like estrogen, like a combined oral contraceptive, or they might be better off with, say, a Mirena or a Liletta or Skyla that releases a little bit of levonorgestrel. That will lighten periods and ease cramping. How important is it to maintain spontaneity of sex? If you have to stop what you're doing to use a method because it's one of the ones that has to be used every single time you have sex, and you're not likely to stop what you're doing, your method's going to fail. What is the patient's risk for STIs? It's very important. And are they going to use the method consistently? For example, somebody who forgets to take medications every day or who has an irregular schedule might not want something that they have to think about every day. All right, and we're going to stop there. I know this was long, but